Step into the reception area of almost any medical practice today, and you will see the exact environment where structural revenue leaks begin. Staff are simultaneously answering landline calls, managing clipboards of patient paperwork, and trying to triage walk-ins. According to Kaiser Family Foundation data, 87% of covered workers now carry a general annual deductible, rapidly climbing to an average $1,787, and 32% carry deductibles of $2,000 or more, placing heavy financial friction directly at the check-in window. Because of this higher out-of-pocket burden, patient cost-sharing repayment rates among the privately insured had dropped to approximately 54% even before the pandemic, according to the Journal of the American Medical Association. This pie chart visualizes the total composition of provider bad debt today. Crow RCA benchmarking analysis isolated this data and found that 58% of that bad debt now originates directly from patients with health insurance. Having an insured patient population does not guarantee practice revenue. Capturing what is owed requires rigorous, structured collection at the point of service to protect a clinic's solvency. The copay collection process breaks down at the front desk, but not because the staff or the software are inadequate. It fails because the people responsible for having difficult financial conversations are also tasked with scheduling, fielding phone complaints, and processing prior authorizations. In that high-pressure environment, explaining a deductible reset or an unexpected balance creates friction. When the waiting room fills up, those complex financial conversations simply get abbreviated or skipped entirely. This line graph illustrates what happens when those conversations are skipped. Health affairs research shows a steep decay curve in repayment probability. The chances of collecting patient obligations drop dramatically the moment that patient exits the building. The pressure of this multitasking environment drives a massive operational problem. Data from the Medical Group Management Association shows front office support staff turnover at a rate of 40%. Finding and training replacements carries a steep penalty. Replacing a single front desk employee costs between $9,000 and $12,000, completely excluding the revenue loss during the new hire's learning curve. Expecting high turnover, overextended in-house staff to secure a clinic's most critical financial touchpoint creates a continuous, unsustainable cycle of uncollected debt. To fix the collection pipeline today, practice leaders are entirely removing this task from the physical front desk. They are shifting from in-house generalists to dedicated, outsourced copay specialists. Healthcare finance researchers identify 3 core best practices for improving cash flow: collect at the point of service, verify insurance eligibility prior to visits, and assign billing to dedicated staff. Staffingly's virtual specialist model implements these exact practices in a linear, focused workflow. By working remotely, specialists handle patient collections without the physical distractions of managing a clinic lobby. This model deploys rapidly. The system connects to over 50 existing electronic health record platforms and goes live within 48 to 72 hours, completely bypassing the traditional 90-day recruiting and training cycle. Offloading this single, high-friction task transforms copay collection from an informal chore that staff avoid into a highly standardized, predictable revenue pipeline. This map demonstrates AI-driven automation layering over the collection process. Incoming tasks filter through a central AI node, distributing assignments based on capacity. Paired with SLA monitoring, if a task approaches a deadline, it automatically shifts to available personnel to clear the alert. The technology also standardizes direct patient communications. AI voice neutralization ensures that every phone interaction sounds crisp, professional, and clear, regardless of where the dedicated specialist is physically located. Securing this digital workflow requires mandatory compliance infrastructure. The entire process operates under HIPAA, SOC 2 Type 2, ISO 27001, and HIT Trust certifications, ensuring patient health information never leaves the primary EHR system. Modernizing the revenue cycle requires both elements: the focused attention of dedicated human specialists, paired with rigorous technological safeguards necessary to securely scale operations. Let's compare the strict mathematics of a broken in-house system against this modernized outsourced model. Looking at these numbers side by side, hiring a single in-house administrative staff member costs a practice $35,000 to $50,000 annually. A dedicated Staffingly virtual specialist working full-time costs $21,600, representing a 55% reduction in baseline cost. For clinics running a larger front office, that math compounds quickly. A practice outsourcing 3 to 5 full-time collection positions generates an estimated $100,000 to $200,000 in annual operational savings. Over 800 healthcare practices have already adopted this exact infrastructure to bypass local staffing shortages and repair their revenue cycles. Practice administrators can initiate a 30-day free trial of the Staffingly model to immediately plug the revenue leaks occurring at their front desk. Surviving the rising operational costs of modern healthcare requires abandoning outdated staffing strategies. Specialized, tech-enabled operations are now a requirement to actively protect a clinic's bottom line.